Hi, everybody. My name's Adam Smith from Nobel Media, and it's my pleasure to be your moderator and guide to this discussion panel and audience Q&A, a mixture. The purpose of this session is for the panel to have a discussion with each other about some of the implications of stem cell research for both patients and society at large, and also for them to have a discussion with you. So at various points during the coming 50 minutes or so, I will be opening out to the audience for questions, and we have circulating microphones. I just want to check before we begin, who was at Shinya Yamanaka's lecture? Please raise your hands. Ah, wonderful. Okay, everybody. So you don't have to say quite as much as you would. We have a great deal to discuss. I don't know whether I even need to introduce the panelists, since hopefully there's a lovely poster behind me, and if I do, I'll just get the pronunciations right, but I'll give it a go. Birgit Skarstein, Anna Smajdor.
Smajdor.
Smajdor, you see I went wrong already. Morten C, and Shinya Yamanaka. Welcome all, thank you for being here. So, Shinya, you in your talk outlined really your vision for how stem cell research is going to help the lives of patients, and your vision for the medicine of the future to a certain extent. I thought it would be very nice to have you, Morten, just as a practicing ophthalmologist, somebody who's working with patients, trying to implement these technologies, just comment on what Shinya said in his lecture.
Yes.
About that.
It was truly a really inspiring lecture. I think all that were there really felt energized and inspired what you're talking about. And this is really what it's all about, because we are getting now into a new area as treatments. We don't only see at the patient's symptoms. We don't just see at rashes, headache. We can really truly study in the lab the disease, the cells of the diseased patient, about cellular mechanisms of the different diseases. And even more importantly, now we don't need to only treat these symptoms, we can actually heal and cure the patients. So for instance, in diabetic, instead of just giving these insulin injections many times a day, we can transplant cells and heal the patients. In age-related macular degeneration, as you talked a lot about today, we as ophthalmologists, we work evenings and Saturdays to treat these patients, and they have to come into our clinic every 4th week to get an injection into their eye. In the future, we might actually be able to cure these patients, so we get a better life, and of course the patient get a much better life. Same with Parkinson, no drugs, maybe a cell transplantation. So this is so inspiring, and of course it will take a lot of time. It will cost a lot of money, but we really hope that this is the future.
Thank you very much indeed. Well, there are so many things to explore. We need to explore questions of cost and access and communication. Let's do as much as we can during our coming time. But let me start with a rather fundamental ethical question. Shinya, at the beginning of your lecture, you said you set out to create iPS cells because of your feeling that might get around the ethical questions surrounding the use of embryonic stem cells. Do you feel that they have circumvented that problem? Are the ethical questions solved?
Yes, I hope it's on.
Yes.
So, okay, good. So, yeah, you're right. My initial motivation was to overcome the usage of human embryos. And now that we can make iPS cells out of your skin or blood cells, I would say it's kind of difficult. Like 90% we have overcome that issue. The remaining 10%, we still don't know how much exactly identical ES cells and iPS cells are. They're very similar, that's for sure. So I believe almost 90% of applications, we can use iPS cells instead of ES cells. But the remaining 10% we still don't know. We still need to use ES cells, human ES cells. But hopefully, in the very future, we can replace ES cells with iPS cells. So that's good. But it's like every other science. It's just like double-edged sword. We have overcome the usage of human embryos, at least 90%. But I realized we are making new ethical issues. That's what I have been struggling with. For example, in one of the questions, I described how to make human organs in large animals like pigs. That kind of research is going on. It's very promising. But it's very controversial. Some people are strongly against that kind of approach. And also, at least in theory, we can make human egg or sperm from iPS cells. That means we can make sperm or egg from your skin or blood cells. Yeah. So that's another, even bigger ethical issue. Yeah. So I worked on iPS cells, trying to dissolve one ethical issue, but I end up making new ethical issues. That's dilemma.
Anna, as a philosopher, would you want to comment on that?
Yes, I think it's sort of ironic that science tries to solve an ethical problem, as you say, but it's like the Greek monster, the Hydra. You cut off one head and several more grow in its place. And I think part of the reason for that is that science isn't that good at solving ethical problems. It's quite good at solving scientific problems. But the ethical problems need to be solved in some other way. And I think one of the reasons why new developments in science tend to raise all of these new ethical problems is often because we don't foresee what's ahead. We don't foresee what's on the horizon, and we're taken by surprise. And the things that we can suddenly do now with cells give us a whole range of new possibilities. So we may not need to use embryos in order to create stem cells anymore in the majority of places. But now we can do all these strange and unusual different things with cells. And just to pick up on that last point about sperm and egg cells, that's a really major new way of thinking about human reproduction, where you could pick a skin cell off a chair or table and take it off and get it turned into a gamete. So I think it's really important to try and think ahead about what the ethical issues are likely to be, and maybe not so much expect scientists to be able to solve those ethical problems, but to place more responsibility on members of the public and on philosophers to try to participate in the direction of scientific research and not get taken by surprise by these kind of things.
But given that the pace of science is actually taking the scientists by surprise, it's almost impossible to imagine that society could be fast enough to sort of keep pace. I mean, Shinya mentioned that there was this change in the legislation in Japan, which slowed everything up because people had to redo their paperwork. And that's one way society responds, just to say, hey, hang on. But that's not the most helpful response. I mean, does it open to all, but how do you structure a societal debate that can keep pace with this extraordinary pace of science?
Well, I would say one thing that we have to acknowledge, and this is probably going to be unpopular, is that to slow things down is not necessarily bad. If there are ethical problems, we need to understand them. We need to understand the implications of the science. If we always have the default setting, whatever social and ethical parameters we set have to facilitate the scientists. That is no ethical engagement at all. We're just being the handmaidens of the progress of science. So I think we do need to think ahead. It is very difficult. Science moves quickly. But if we forestall the idea that there might sometimes be grounds for delaying scientific progress, we might as well throw our hands up and say, let's just wait and see what happens. So it's, you know, ethics isn't always about steaming ahead in the right direction. It might be about trying to work out what the right direction is and not moving until we know.
Birgit, you wanted to comment on this?
Yeah, I would say that, well, I'm here from the Norwegian the Norwegian Board of Biotechnology, and I would say that is exactly why we have these kind of boards, national boards, that can look into the issues and see, okay, we have a new technology here. What is the power of this technology? What will this, maybe not today, but in the future, what will be the consequences or the possible consequences of this technology? And then do an ethical discussion on that and see what kind of society do we want and what kind of society do we not want. And by having those kind of national boards of biotechnology, you have a fora who can actually be updated to science as of today, what is going on out there, and see, oh, shoot, something's going on. Let's grab this and see, oh, what is this going to be? What is it today? What can it be tomorrow? What can it be in 5 years? See what is the ethical aspects of that we have to discuss. And then it's up to us in the boards and as people with ethical perspectives on medicine, to take that debate into society and make sure that people who don't read magazines or don't read about the progression going on can be updated on what's happening so that we can actually get a debate that hits people and do things like you guys are doing now. We're at the university where people read, where people are interested in learning, and tell them, see. And then it's up to you guys to actually take this discussion further than this room.
Morten.
Yeah, I partly agree and partly disagree that we have to slow down. I think we as doctors, we have these patients every day. I think all felt it was a special moment in the room when we were seeing this kid raising his one finger and helping for fast science to cure his disease. But then it's an ethical dilemma because then we have to, as clinicians, also to slow down a little bit. Our kind of main goal that we have learned at medical school is primum non nocere. First of all, not make any harm. So the patients are also pushing here to get this treatment, and then it's extremely important that we know that we do not do any harm. It's no harm for the patient. I think that has to come very, very early. But as clinicians, we are feeling this drive to help them, and this is why we are also trying to push hard.
Shinya, let's come back to that finger. And throughout your lecture, you stressed the importance of moving fast. So, with particular reference to this point of Anna's and the idea of working with governmental organizations, what do you feel about slowing things down?
Well, I think you're right. We have those patients eagerly waiting for new therapies, any therapies. So just slowing down is very tough on us scientists, also on patients waiting for any new development. It's the hope, regardless the result of clinical trial. Just knowing someone is working on their own disease makes them a huge difference. Previously, they felt they were kind of abandoned. Nobody is doing any research on their diseases. But now with iPS cells, many researches are going on. Once again, it would take many years. So most likely, we cannot make it for the present in front of us. But still, it's a hope for them. It makes a huge difference to the patients and the patient's family.
Okay, I want to come to you both on this. Okay, Anna, go, and then I want to come to Birgit. Yes.
Yes, I think that's a really significant aspect of what drives the momentum of scientific progress, both, of course, the interest of the scientists to discover new things, the clinicians who want to help their patients, and the patients who don't want to feel abandoned, as you say. And I just want to clarify, I wasn't saying research should always be slowed down and preferably stopped. I just think that has to be an option on the table if we're genuinely thinking about ethics. But to come back to the point about the patients and their need to feel that something is being done, I think that's a really ethically problematic environment to be working in. I'm not sure how one could get out of it, but there's a kind of symbolic value that the science has that is separate from its capacity to actually benefit those patients medically. And so we're pushing science forward, trying to speed it up for the sake of a kind of symbol to show these patients that they're not abandoned. And I think that's something that is worth thinking about carefully, and whether it's worth separating those two things out. Is that symbolic value of scientific advance something that we should be acknowledging maybe more explicitly? Maybe there are other ways of making these patients not feel abandoned without driving science forward. So I think being clear about where the medical benefit is or where the symbolic benefit is might be an important thing to think about in that context.
Thank you. So Birgit, let me come to you there, because you're here with two hats, if you like, partly from the Biotechnology Advisory Board, but also as somebody who has been, if you like, the recipient, the beneficiary of that hopeful message. You yourself suffered a paralyzing injury, and so have experienced what it is to hear the message that there is research going on that could help. Can you talk about it a little bit?
Well, I could say it goes both ways. The day I were back in the hospital, you know, because I had a spinal cord injury when I was 20, and we didn't know the outcome yet. So I was back into the hospital, and I remember it really well, because I was sitting together with my mom, opposite of the two doctors, and my mom, she looked at them, straight to them, and of course everyone was wondering what's going on. And my mom looked them in the eyes, and she said, is Birgit ever going to walk again? And it goes all quiet in the room. And then one of them, in the end, said, well, there is a lot of really interesting work going on stem cell therapy in China right now. And that's 8 years ago. And obviously you beat China. But getting that kind of a message, as you say, in one way, it is a no, probably not. In another way, it's, well, maybe. And for people that cling to that hope, it could slow down the progress of accepting. It could be clinging on to hope, which is non-realistic. It could also be clinging on to hope, which is realistic. Anyways, that hope is a great power, very, very great power. And it means a lot to people in their lives. Like you're saying, people are dying, and they're saying one day earlier. But the way you communicate it, that's the really tricky part about it. Because, well, I'm actually wondering what all you guys are thinking about it. Because in one way, you need to get it out that it's going on, but still make sure that the effects and how far we've come, and as you said yourself, time, cost, all those things are actually passed on so people can understand it.
It's a general problem in science research that expectations through communication become greater than reality. Exactly. In this case, there's a particularly strong link. How does one cope with that? That you want people to support, you want people to be excited by what's going on, and yet you want people also to understand that it's going to take a lot longer than the excitement might indicate?
Well, I would say the lecture, like the one we've seen today, is one of those that is really reality-oriented, which is on the one side saying, this is happening, and we're making something come true which people have never thought it was possible. Just some years ago, we would think it was impossible to do what you're doing now. It's happening, and you're thinking outside of the box, and you're going new directions, and suddenly a whole new world opens. Suddenly, you're talking about a cure for ALS. It's extraordinary. On the other side, actually saying it's going to take time, and we need to support over time, and maybe people should not put their hopes today on the medicine of tomorrow, except that knowing that steady state working might make it happen.
Anna, do you want to comment? Do you want to continue on this? Because there does seem to be a danger in over-expectation.
Yes, and I certainly think if you look back to the Human Genome Project and the early days of embryonic stem cell research, you can see in both of those areas that there were huge expectations, that the newspapers were full of stories about how patients would be able to grow new organs for transplant, and they were going to find the gene for absolutely anything you can think of. And in both those areas, the actual scientific basis for the claims that were being made, I think, were much more shaky than people realized. But people were very optimistic. And I think, especially in the context of embryonic stem cell research, part of the reason for that is, certainly in the UK, where I come from, there was a kind of fight between the scientists and some of the public about whether it's okay to use embryos. And the scientists and the media started to say, we have to because of these great things that we're going to achieve. And ultimately, of course, not that much time has gone by since then in terms of the length of time it takes to get from laboratory to clinic. But it seems clear that embryonic stem cell research is not going to deliver those promises as quickly as it said or as effectively, maybe not at all. So I think there was a kind of mismatch between the science communication and the public expectation, which arose actually because of an ethical dispute about the use of embryos. So I think it is absolutely vital to think carefully and sensibly about what the science can achieve, what the goals of the science are, and not to try to oversell it to the public, and to have a public that is educated and critical and able to think about the information that they're being given, and also what they want, how they want to have it. So those are very important considerations, I think.
Thank you. Thank you very much. Yes. Birgit, then Morten, and then we'll go for questions.
Well, I'd say that everyone should take their responsibility. The public opinion, people should read about it. They should think about it. What do we want? What is going on? They should be well educated when they express something or discuss to figure out what is this. Scientists should be really sober when they talk about it and talk about the expectations and of course the hopes, but still what can go wrong. And I think the media definitely should take their responsibility to not go for the temptation of putting on the front page, this is going to cure cancer forever. Don't do it. Don't. Be responsible. Don't communicate things which is false. But and just a question to you, Yamanaka, what do you think about media when they cover your field?
So they are doing very difficult job. They have to sell newspapers. So they tend to say either black or white, either hope or hype, right? But we have been spending a lot of time. In our own institute, we have a group of so-called science communicator. They used to be scientists, But now they try to be communicators, professional or speaker. So the point is, we scientists need to be as transparent as possible and also as accurate as possible. What kind of research we're doing, how much hope we can expect, but how much risks we are facing. So that kind of transparency is very important. But at the same time, we scientists are competing with each other. Sometimes we need to hide our data prior to publication. So we scientists are having a hard time between being transparent and being competitive. We have that problem. So scientific media people, I can imagine they are having even harder time because we cannot give them 100% of the information we have because we want to be transparent, but we really need to hide to some extent. So that's the dilemma we have and media people have. So it's a very difficult task we're facing.
Morten, you wanted to comment quickly.
Yeah, I think the patients are very well educated. They read a lot in the internet. These days, this word user involvement that has to be in all applications. And people will ask me, what do I write in this chapter, user involvement? Go talk to the patients. They are very well educated about their disease. And this interaction with the patient, talking to the patient, and they can inform you, and you can inform them, it's very dynamic. And if the patients say to us, I don't want to know information about one another gene, I want you to develop therapy, we are kind of obliged to listen to that and at least try to speed up the process towards clinical treatment.
Okay, so much to discuss, but let's go for some questions. Please, here in the front.
Thank you for eliciting this interesting debate. And actually, I want to add, I'm a stem cell scientist and a clinical immunologist working in the field of hematopoietic stem cell transplantation, and I have as much experience in true stem cells or patient stem cells rather than iPS cells. However, we're currently working with iPS cells. So, in addition to what Professor Yamanaka said regarding the internal scientific debate, transparency, and competition, there's also belief. There's lack of publication of side effects. You always publish the positive effects. Hardly you find publications regarding other side effects. In addition to the internal scientific belief, regardless the transparency, that people working with original cells are biased towards, I'm one of them, although currently working in IPS, biased towards original cells rather than IPS. And that was my question regarding the trial with the patient one, that you're using mesenchymal stem cell derived from IPS rather than original mesenchymal stem cells.
It's iPS cell derived MSC.
Yes, rather than mesenchymal stem cell derived from the patient, not IPS derived.
Oh, I see. So, yes, those patients, even very minor injury can trigger ectopic bone formation. So, even when we try to generate iPS cells, we were very worried because we did skin biopsy, very small skin biopsy. We may thought that small procedure may activate ectopic bone formation. But fortunately, it didn't cause. So trying to mesenchymal stem cells out of the patient directly is a bit bigger damage to the patient. So I don't think we can do that.
Yes, my point actually, I'm sure that there was an answer, but my point is there's also an internal scientific debate, and I may a bit disagree with that the patients are very well educated, because it's really very deep science. So patients read the general public, and scientists are still not settled yet. So maybe I a bit disagree with that they are very well educated.
I mean, it is a general problem in all fields of life, not just science, but certainly in all fields of science, that if you tell a story and you say, but we're not so sure, then people are going to start losing faith in you, and your funders are going to start worrying. So there's a whole machine around generating stories that hang together and keeping the so yeah. I don't know if that's a big topic to tackle for the panel, but it's very, very germane to this issue. Does anybody want to comment on it? You can, please, Anna, quickly.
Yeah, I think the point about scientists being in competition with each other is a big problem for, if we think that the aim of science should be human benefit, then it may not serve that goal to have scientists in competition, which then leads to this need for secrecy. And I just also wanted to comment on the structure of academic life, which I think has many inbuilt ethical problems associated with it. So when you seek funding, you have to make very optimistic claims. So you have to make claims about the big effects that your research is going to have for society. And I think so the comment about negative publications, there's a sort of compulsion to publish things that are good, that are success stories, of course, but actually the whole scientific picture includes the negatives as well. But the academic system tends to encourage people to favour one side of the argument, and I think that is a problem both for patient education and for the broader public understanding. So there's a sort of inbuilt question here about whether we can change these systems. It would be very challenging to try and overcome some of these problems.
I think that's probably a subject for a second session here, the whole publication policy in academia and academic structure. But more questions? Anyone else want to raise a question? While you're thinking, I'd like to ask a question about access to these therapies, because I mean, throughout your talk again, Shinya, you were stressing the expense, and you were finding ways to bring down expense. But everything we're talking about is fabulously expensive. So who is this therapy for ultimately?
Well, of course, we want to do this for all the patients. But in reality, at least initially, many of the new therapies we scientists will generate, will be very expensive. So that's the problem we have. So we're hoping by many ways we can lower the cost as much as possible. But that's a challenge we're facing.
Yeah, and I think that is an ethical issue actually, because then you get the risk that this is a treatment for the rich people that can access to this treatment and go abroad and get the treatment. And this is something we as clinicians also, and all of us actually, need to be very aware of. If the cost rises, it could be a prioritized patient population that get access to it, and that we have to prevent.
And of course, I mean, this isn't a problem that is part of stem cell research only. It's a general problem of all therapy development. But with reference to this, I mean, that there are certain aspects of it which make it perhaps more centralized, and that creates its own infrastructure and expense. What do you feel about this, Birgit?
Well, I, in general, think that healthcare should be given to those who are in the biggest need. I think this is really interesting because, as I see it, it can challenge the infrastructure of healthcare, as you're saying, maybe especially making it more global instead of national. That's actually something I would really like to ask you about, is do you think that this way of thinking medicine and using medicine, do you think that's going to create a bigger global healthcare system, which is not as national as today, where they will move patients or move cells around the world?
Well, hopefully, any new therapies will be as global as possible, not only for one or a few countries, but also for all the patients. Like, iPhone. Everyone in developing countries or even developed countries, many people are using iPhones because the price is not too expensive. So that's a good model. The Apple spend a lot of human resources, a lot of money in developing new iPhones. So they could make the new product even more expensive. But the price is just good enough so that many people around the world can access to it. So I think that's a very good model for new medicine or new medical therapies. If it costs like 0.5 million US dollars, it won't be global, just for rich people or a rich country. So I have been thinking how we can lower the cost. That's, it's challenging.
Okay, Morten and then Anna.
Yeah, and this is why we're particularly interested in also hearing about this auto-transplantation versus allotransplantation. For if you call the auto-transplantation kind of the Mercedes-Benz, which is very expensive, then the Toyota model with the allogenic transplantation might be a little bit less costly. So I think to go for both these ways is very fascinating.
And it's just one technical question from my side. If you go for the super donor route, is that country specific, or can Japanese super donors?
So for each country or for each ethnic group, the distribution of HLA haplotype is different. So our super donors in Japanese population is only for Japan, maybe Korea, that area. So UK has different distribution. But we are now trying to generate international collaboration so that we can facilitate more that kind of super donor identification.
Sure. Yes. Thank you. Anna, sorry.
Yeah, I think the analogy of the iPhone is very persuasive, and I've used it myself on occasion. But I think there's a problem with expecting stem cell therapies to sort of globalize in that same way, because some of the biggest problems that we see health-wise arise from systemic and infrastructural problems. Now, those problems don't necessarily stop someone from getting an iPhone, but they might well stop someone from accessing hospital, from having laboratories that have the right facilities to enable access to this kind of medicine. So I think it is a really appealing idea that if you just create these things, there will be a trickle-down effect. But somehow in healthcare, that just hasn't happened. And so we have huge health disparities across the globe, which I can't see anytime soon, this kind of therapy being rolled out across Africa, for example. And that raises a big question of, well, what should we do about that? Should we go ahead anyway? Does it matter that we may be actually widening the health disparities that exist in the world? So I think we need to be skeptical about the idea that there's a sort of even spreading out of these innovations in medicine that will eventually benefit everyone. And we should bear in mind that the diseases on the whole that these therapies are going to address are the diseases of affluence, with the exception of the spinal cord injuries. Parkinson's disease, the diseases that you get if you live to a ripe old age in a well-fed environment, age-related macular degeneration, type 2 diabetes. So I think there are huge global ethical problems in that context.
Certainly, you must be right. But on the other hand, there is trickle-down, isn't there? There always is trickle-down, so that you can't have a perfect system. I mean, there will be benefit, even if you develop medicines for only that population.
I know that a lot of people think that's the case. I have recently read things that made me think it may not be so. I mean, this is a very ideologically loaded sort of argument, and it's very difficult to prove empirically. But there seems reason to think that the disparities between different economic groups are growing, and the associated health disparities also grow. So we can't just make the assumption that these developments necessarily benefit everyone. We have to be open to the question that they may not. And I think that is an open question. I'm not satisfied that we can sit back and wait for these things to happen. There are these big problems that exist in parts of the world that aren't going to be solved by stem cell therapies, but need huge amounts of economic and political input before we even start thinking about that kind of thing. But this applies very much to any sort of medical innovation, but it is, it's there and we have to recognize it.
Thank you. Morten? And then
I partly disagree with that, but I think it's a very interesting comment. But for instance, diabetic is like an epidemic all over the world, and also very much in the poorer population. So if you can come over using this technology to make this little step, probably this technology will then dissolve to other type of diseases. So I think it's extremely important to take the first steps, and it will have global effects.
Thank you. But is there anybody else? There must be somebody else. Come on. Be brave. This is your chance.
Just stemming from the current debate, I was thinking, how would super donors be generated in a multi-ethnic world? Like we have mixed gender, multi-ethnicity children now, and a lot more with the globalized world, right? So how would super donors work in that? And isn't autogenic a better solution in that sense? And what really is causing it to be so expensive? Like, how can we actually bring down the cost of autogenic IPS?
So in Japan, in order to cover like 90% of all the Japanese population, we need to have 140 super donors. The first two super donors can cover almost 30%. But in order to cover the rest, we need more. So in total, 140 super donors would cover 90%. One of the most diverse countries is probably US. They have Caucasian, they have Hispanic, they have Asian, they have African American, at least 4 major ethnic groups. And to cover like 80% of each ethnic group, they would need to have 200 super donors for each ethnic group. So in total, it's much larger number. But still, it's durable. Instead of making tens of thousands of HLA haplotype iPS cell stocks, it's still durable. And we're hoping with lower cost. And by utilizing genome editing, we may be able to generate super iPS cells, which won't cause any immunological reaction. So actually, that's what many scientists and some companies have been working on, to make just one global iPS cell line.
and very, very briefly, just answering the second part of her question, why is the autologous route so expensive?
At the moment, the efficacy of iPS cell generation is too low. So it takes too long. And also, we see a huge variation among iPS cell lines from each individual, even from the same individual. If we generate like 3 iPS cell lines, they are different. So we need to select the best line from each donor. So if we go with autologous, we need to do it many times. So we have been trying to overcome those practical issues. Once we overcome such issues, we can do autologous, I believe.
Thank you. There's a question there, Birgit. You wanted to come? Did you want to come in?
I can do it after the question.
Okay. Yes, please. There was a question back here. Oh, has the microphone not arrived to them?
Yes.
Oh.
I have a question regarding your super donors and super donors and so forth.
How much do
What-
they earn?
Yeah, what do they earn? No. What age are they? I mean, there must be some criteria on how you select your donors regarding, for example, telomere length and also considering the treatment of the patient and these cells and how they're going to function for years on.
Yeah, that's a good point. So we are now making iPS cell stocks from peripheral blood as well as cord blood. And cord blood is actually 0 year old. And we found cord blood is probably better origin because they don't have any acquired mutation, whereas peripheral blood from like 50-year-old healthy looking donor, they have acquired many mutations already. So each of us are not free from mutations. Yeah, I became 55 2 days ago. So unfortunately, we have many mutations already. So cord blood is probably the best way.
And your joking question actually raised the whole issue of rights to this material, which is something that we may not have time to cover, which we wish we could. But Birgit, now do you want to make your point?
I can do it now. Well, it's not a point, actually another question. I was just wanting to ask you, because your science has definitely opened a huge door into a new world. And if you look 30 years ahead, what field or what area do you think has been affected most by your search and your findings?
Oh, it's next to impossible to make prediction. But at least, we really want to contribute to 2 areas. One is cancer, and the other one is rare diseases. So those are the 2 areas we really want to contribute, together with many other applications. But what I would want to stress is that probably after 30 years, we should have completely new technologies, which we cannot even imagine. 30 years ago, nobody were able to imagine like iPS cells. Nobody were able to imagine genome editing or even sequencing of our genome. Just 30 years. I was a medical student 30 years ago. I didn't learn anything about iPS cells, genome editing, or even hepatitis C. So after 30 years, I hope I can survive 30 years so that I can watch by my eyes. But it's very promising, I guess. After 30 years, iPS cells may be already very old, maybe a history. Probably it's going to be a history. We should have some other better technologies after 30 years. That's science.
Just to close, that brings us back to the question of how society can possibly prepare itself for the unexpected developments. If it doesn't, one solution, as you said, is simply for science to lead society wherever it's going. how else can it be? What do you think?
So, well, so I think people should be flexible, should be open-minded, so that they can allow so-called crazy scientists can do their own science in order to make progress. For example, in vitro fertilization. It's now just a common procedure nowadays. But just 30 years ago, they thought many media people thought it a crazy approach, right? But now it's just many children born that way. So we should remember that history. You know, any new scientific technology may be regarded crazy or something invading God. But we should be more open-minded, I believe. It's difficult, you know. Kind of, sometimes it's scary, but that's what I think. At the same time, we scientists need to be as transparent as possible, even in this severe competition.
Well, as you say, a conversation like this is a step in the right direction. And unfortunately, we are out of time, but I would like to thank you all for what has been, I think, a very engaging conversation between the four of you and the audience. Thank you very, very much indeed.
Thank you.